Bilateral scapular fractures are rare as significant force is required to cause this injury. There are only 18 reported cases of bilateral scapular fractures in the literature, and of these, only 6 are reported in the absence of high-level trauma. These are instead attributed to seizure or electrical shock. Herein, we report a case of bilateral scapular fracture without a high-energy traumatic mechanism and without history of electrocution or prior history of seizure. This case aims to provide an example of a rare presentation of injury and the need for a high index of clinical suspicion for seizure in such a scenario. This case is unique in the fact that while posterior shoulder dislocations are common in the presence of seizure, there are rare instances of scapular fractures associated with seizures as well. Our case centers around a 32-year-old male with no past medical history presenting for shoulder pain. He states that he was working on his computer at home when he experienced a sudden onset of forceful vomiting. He fell to the floor from his chair, striking his head on the armrest, and awoke on the floor an unknown period of time later. He has no known personal or family history of seizures. Upon awakening, he began experiencing bilateral shoulder pain that radiated to his back. The patient's physical exam was notable for an abrasion with overlying contusion in the area of his head strike and tenderness bilaterally over his scapula. Labs were significant for a CPK of 868 and a leukocytosis of 22.1, and a UDS positive for ecstasy, opiates, and THC. CT chest abdomen pelvis was notable for comminuted left scapular neck and body fracture with extension to the scapular spine and right-sided non-displaced medial scapular body fracture without angulation or deformity. Due to these findings, the patient was admitted to the trauma service for orthopedic and neurologic consultation. Orthopedics opted for non-surgical management for the scapular fracture and splinting with a sling instead. Neurology performed an EEG, which did not show any epileptic activity, but given the patient's overall presentation, anti-epileptics were recommended upon discharge for a suspected seizure. Patient was started on daily lamotrigine for seizure prophylaxis. Key takeaways from our case include, in patients with scapular fractures without a history of high energy traumatic mechanism, the provider should maintain a high index of clinical suspicion for seizure as the underlying cause, and neurologic consultation should be sought. Overall, scapular fractures with or without high energy traumatic mechanisms are rare, and thus careful consideration and review should be conducted to prevent missed events, especially in polytrauma cases. The consequence of missed scapular fractures is ongoing significant pain, but in only one case did the patient undergo surgical management. Lastly, splinting by and large is the preferred management option for scapular fractures.